Good afternoon. This is Dr. Sonal Mehta. I am lead medical advisor, Intas. Intas is a leading pharmaceutical company having presence in more than 70 countries, and it has strong presence in fertility business. Being a knowledge partner and continuing the commitment for scientific update and to engage you all during this COVID-19 outbreak, Intas Women Health team headed by Mr. Satpathy have organized this webinar. I welcome you all to the webinar on enhancement of endometrial receptivity in ART program given by Dr. Chaitanya Nagori. You all are requested to put your questions through the chat box. Regarding Dr. Nagori, he is director of Dr. Nagori's Institute of Infertility and IVF, Ahmedabad, and doing exclusively infertility practice since last 25 years. He is pioneer of ART. To his credit, he has more than 1,000 pregnancies in long-term infertility patients, several papers presented at national and international conferences, invited as guest lecturer in various state and national conferences, and more than 800 lectures on infertility. Achieved first pregnancy in a patient after endometrial regeneration by stem cell in a patient of Asherman syndrome. Best paper award at 18th World Congress of Ultrasound on OBGY, Chicago, 2008. Publication in national and international journals. Authored, edited, and contributed in several books. Conducts regular teaching program on infertility for practicing gynecologists. Foxy Recognized Training Center for Infertility and Ultrasound. He has trained more than 800 Indian doctors for infertility and IUI. Faculty of Donald School of Master's Course of Human Reproduction, Croatia. Received ET Conclave 2019 award. Dr. Nagori's Institute is also a center for training for Donald School Fellows for Masters in Human Reproduction and Ultrasound in OBGY. This is not the complete thing, but these are the highlighting point of Dr. Nagori. Today we are fortunate to have with us two eminent clinicians, Professor Manal Taha and Professor Dr. Mohammed Saheb. Dr. Manal Taha is clinical infertility ART specialist, dean of High Institute of Infertility Diagnosis and ART. Professor Mohammed Saheb is he is professor at Al Nahri University, president. With this, I welcome Dr. Manal Taha.
Thank you, Sonal. I would like to welcome Professor Dr. Nagori for accepting our and Intas invitation for giving this lecture, and also to many thanks Intas company to allow us to make this webinar with the Indian nice people. Thank you so much.
Just a second. Respected Professor Manal and Professor Mehmet, I would like to talk today on enhancement of endometrial receptivity in ART program. Endometrial receptivity is defined as a state when the endometrium allows blastocysts to adhere, penetrate, and implant in the endometrium after inducing the stromal changes. The implantation rate is 25 to 35%, and the endometrial receptivity is still remains the challenging. Receptivity is maximum after 7 to 10 days of endogenous LH peak. So it corresponds to 19th to 24th day of the menstrual cycle, that is day 4 or 5 after the progesterone secretion. This physiology is very important because the blastocyst transfer should be done always after 4 to 5 days of the progesterone. Window of implantation and receptivity, they are the synonyms. These are the transient functional changes: ovarian steroids, immune cells, cytokines, chemokines, adhesive molecules, all are responsible for these changes at the time of the window of implantation. Now, during window of implantation, appearance of pinopods play a very important role. Some genes are increased and some are turned off temporarily to establish the pregnancy. So these are the functional changes which occur at the time of window of implantation, which are very important. Now, physiology of uterine receptivity, there are only two hormones which are responsible. One is estrogen and second is progesterone. Estrogen stimulates an expression of the progesterone receptors. Now, this is very important that the estrogen can give you a progesterone receptors, and that's why sufficient amount of estrogen has to be given prior to starting of the progesterone. Estrogen upregulates VEGF, IGF-1, IGF-BP. So these are all upregulated, and it helps in upregulation of the anti-apoptotic genes. While the progesterone helps in penopod formation, down-regulates the estrogen receptors, down-regulation of LIF and beta-3 integrin, upregulation of all these cytokines which are important for the implantation. So upregulation by progesterone and downregulation of the estrogen receptors, these are very important things as far as the implantation is concerned. Now, this endometrial receptivity can be diagnosed by, one is a transvaginal ultrasound with the color Doppler, second is morphological changes, third is analysis of the biomarkers, and fourth is the endometriomics. Now, the transvaginal ultrasound, endometrial thickness should be 7 millimeter or more, preferably 8 to 10 millimeter. Morphology should be triple line, grade A or B morphological pattern, and vascularity in zone 3 and 4. This is the picture of endometrium, where triple line endometrium with echogenicity in between is an excellent endometrium, that is grade A endometrium. Now, there are several reports by the different group that agree on the fact that the implantation rate can be more correlated to the vascularity of the endometrium rather than the thickness and morphology of the endometrium. In a pre-ovulatory study, the segmental uterine artery perfusion demonstrates significant correlation with hormonal and histological markers of uterine receptivity. So what does it mean? That if the vascularity is present, then and then you will see the hormonal and histological markers present in the uterine endometrium. So that indicates the receptivity of an endometrium. Absent as subendometrial and intraendometrial vascularization on the day of the trigger appears to be a useful predictor of failure of implantation in an IVF, irrespective of morphological appearance. This is extremely important because there are a lot of centers in the world who don't use color Doppler in their practice and they do a transfer. I'll tell you what happens because of it. So endometrial vascularity, here you can see that zone 1, zone 2, zone 3 and zone 4, particularly zone 3 when it enters the endometrium and zone 4 when it touches a midline. This zone 3 and zone 4 vascularity are extremely important as far as the implantation is concerned. Endometrial and subendometrial vascularization may serve as a prognostic marker for ongoing pregnancy, unlike any other markers of endometrial receptivity. So no other marker can compete the vascularity of an endometrium. Endometrial vascularity and its relation to implantation rate, this was the paper which has been published, and this indicates that the pregnancy rates are very high when the vascularity is zone 3 and 4, and pregnancy rates are high and the abortion rates are very low. Doppler of the endometrium also, that is very important, that gives a good pregnancy rate. And the best part is that uterine artery PI. If the uterine artery PI is between 2.2 to 3.2, then only the pregnancy rates will be very high. If the PI is more than 3.2, even if you transfer your embryos, the implantation is not going to occur. So just I summarize that 8 millimeter endometrium with a grade A or B with zone 3 to 4th vascularity, RI less than 0.6, uterine artery PI less than 3.2, volume 3 cc, FI more than 20 and VFI more than 5. If you get this type of endometrium, then and then your pregnancy rates will be very good and the embryo transfer should be done only at that time. Morphology, second will be morphological changes. One is the dating of endometrium, second is the penopods. And recently the noise criteria has been questioned and it has very low predictive value for implantation and that is not considered now. Same like penopods, there is a strong disagreement to the timing, functions and clinical value of penopods. And so the conclusion is that the morphological changes are not used clinically for endometrial receptivity. Third will be biomarkers. These are the biomarkers, and these biomarkers individually can be tested that what is its presence and how much it is present at the time of endometrial receptivity. What I would like to emphasize you one thing only here, that these are not the causes that the endometrial the endometrium is poor, receptivity is poor. See, these are the results rather than the causes. And these are the results of the estrogen and progesterone, and that is why the endometrial receptivity is poor. Immunohistochemicals, there are so many biomarkers, so much research is going on all these biomarkers, but ultimately it has been found out that these are the results rather than the causes of endometrial receptivity. Integrin also is considered, but there are controversial results that it is very good for endometrial receptivity. At present, the era is very popular. Endometrial receptivity era is going on all over the world. It is a customized microarray for 248 genes involved in endometrial receptivity. It determines whether the sample is collected in window of implantation is receptive. Large variations in genes, variable expressions, and these variations are not reflected at the protein levels. These are the limitations. Second thing, moreover, it requires endometrial biopsy in the previous cycle. So you have to freeze the embryo. So the cost of freezing also is very additional. It is not recommended by the Human Fertilization and Embryology Authority. Endometrial function test and receptive DX test are under the trial. So what I want to emphasize that endometrial receptive array has not been found very popular. And second thing is it is not correlated along with the vascularity of an endometrium. If you compare the vascularity of an endometrium and then you try to find out whether this is in the window of implantation or not, then we can have some substance as far as the test is useful to us or not. Otherwise, endometrial vascularity will be much more reliable than the endometrial receptive assay. Endometrial receptivity, there are a lot of genes from OXA-A10 and A11 play very important, same like beta-3 integrin and EMX2, LIF and interleukin I said, but all these are effect rather than the cause. Now, how thin is the thin endometrium? 7 millimeter is accepted by majority of the center as the cutoff. But the vascularity is more important than 7 millimeter because pregnancy has occurred from 5 to 15 millimeter of the endometrial thickness. So the thickness receptivity may not correlate with the thickness of the endometrium. And that's why the vascularity is important. And so the molecular technology has now come in the picture, whether it helps us for the endometrial receptivity or not. We have to rule out low estrogen level that is responsible for decreasing in the endometrial receptivity, clomiphene citrate, long-term OC pills, GnRH agonist or antagonist, and progesterone rise on the day of trigger. They all can affect the endometrial receptivity. Causes of thin endometriums, majority are surgical causes, that is dilatation and curettage, partial ablation, aggressive myomectomy or post-Rossmann operation, radiotherapy, infection, congenital Mullerian anomalies, and idiopathic causes. Now, out of all this, obstetric curettage is almost 66.7% of cases you get an adhesions. Puerperial curettage is 21%, and this case Essenman syndrome and is diagnosed by ultrasound and a sonohysterography. Intrauterine surgery, particularly 31 to 45% after hysterectomy resection of the fibroid, and 7% after a surgery done with a bipolar resectoscope. So the unipolar resectoscope is more dangerous, and that's why bipolar resectoscope is to be used. Estrogen or IUCD after doing the surgery does not help at all in prevention of adhesions. Septum resection causes 86%. That's why the cautery is not to be, electrocautery is not to be used to this patient. Polypectomy does not cause adhesions and it improves the fertility if it is more than 1.5 centimeters. So all polyps more than 1.5 centimeters should be removed and they never cause or they never decrease the endometrial receptivity. Strassman operation, that is unification, is almost obsolete surgery because of the cervical encercles and availability of the progesterone. Rarely in complete bicorporeal uterus with repeated preterm deliveries, you may have to undergo the Strassman operation, but nowadays it has become almost obsolete. Intramural fibroids, Fibroid more than 4 centimeter decreases the implantation rates, and removal of the fibroid improves the pregnancy rate. Molecular level is disturbed just like the submucous fibroid. But high frequency ultrasound and embolization has not been studied for the uterine receptivity, and so its final role for achieving the pregnancy is not clear. Hydrosalpinx implantation rate is poor because of the inflammatory fluid. Receptive markers are reduced and markers return to normal level after the salpingectomy. The Cochrane review favors the salpingectomy. Now the radiotherapy. If the uterus is not irradiated, no effect on the endometrium. But older the patients, it shows the better response to the hormones. Decreased endometrial thickness after abdominal radiation never improves. Endometritis, a very common thing that changes the endometrial environment, changes uterine contractility and the wave pattern. May be symptomatic, DUB, pain or leukorrhea may be present. The hysteroscopy is the gold standard that shows the micropolyps and inflammation, hyperemia, edema with almost 93% of the diagnostic accuracy. And that's why hysteroscopy is one of the very important investigation in reduce endometrial receptivity. Tuberculosis must be kept in mind. In our country, the tuberculosis is very common, so we always keep it in mind. Otherwise, endometriosis can be treated with doxycycline 100 mg BD for 10 to 14 days, or azithromycin 500 mg orally on the first day, and 250 mg from day to 5 can be given. Now, the ultrasound diagnosis, no or minimal vascularity in the endometrium and subendometrium. This is very common. Many times you get a good endometrial thickness, but the vascularity is not present. These are the cases of endometritis. 3D ultrasound and sonohysterography may show you scarring and synecdoche. Though the tuberculous endometritis cannot be confidently differentiated from the Asherman syndrome on ultrasound alone, there are certain ultrasound signs more commonly seen in tuberculous endometritis. Thin endometrium, no junctional zone, fluid in the cavity, no vascularity in the endometrium, scarred endometrium, vertically oriented cornu. This is very important sign, that vertically oriented cornu that you can see. Endometrial calcification, these are the signs of tuberculosis. Associated finding in the abdomen are the ovarian calcinosis, particular ascites, and myometrial calcification can be present. Then comes endometriosis. Implantation rate is reduced, and this is because the estrogen receptors are not down-regulated at the time of implantation, and high E2 is detrimental. This is very important, that why the implantation rate is low in endometriosis, because the estrogen level is high. The estrogen receptors are not down-regulated. And as the estrogen receptors are not down-regulated, the progesterone resistance is very common, and normal peristaltic activity is adversely affected. After surgery or after HIFU, markers are not elevated in the comparative studies. And that's why endometriosis is very notorious as far as the implantation is concerned. Female obesity impairs the reproductive outcome of ovum donation, probably as a result of the reduced uterine receptivity. Karyotyping in Mullerian duct anomalies normal in 92% of cases, and there may be an alteration in Hox genes. Future research is required. Now, when the low endometrial receptivity, what is the treatment for this? We have drugs like low-dose aspirin, sildenafil, tocopherol, pentoxifylline, nitroglycerin, L-arginine, estrogen, HCG, GnRH analogs, ovulation induction, and low molecular weight heparin. While we can do the procedures like endometrial scratching, GCSF, platelet-rich plasma can be put, and stem cell therapy. Let us consider one by one. Low-dose aspirin, it increases the uterine blood flow by decreasing the PI of the uterine artery. It minimizes the inflammation, decreases subendometrial contractions. It improves the implantation and pregnancy rates in the older studies, but the Cochrane review in 2010 showed no benefit. Recent meta-analysis in 2017 concluded that it may significantly improve the clinical pregnancy rate. We must be seeing that the aspirin in all the prescriptions to improve the endometrial receptivity, but still its role even today is doubtful. Second is sildenafil, potentiates the action of nitric oxide on the vascular smooth muscle, that is vascular relaxation is found. It can reduce the NK cell activity, Dose is about 25 milligrams 6 hourly, vaginally up to the day of trigger or the embryo transfer. It increases the blood flow to the endometrium and improves the thickness and receptivity. Cochrane review concluded that there is insufficient evidence for the sildenafil to improve the live birth rate. So neither the aspirin nor the sildenafil are useful as far as increasing the endometrial receptivity is concerned. Tocopherol, that is vitamin E, it is a powerful antioxidant and scavenges ROS. It increases the endometrial thickness and decreases the resistance in uterine artery because of the VEGF and vasodilating effect. It may improve the endometrial response in unexplained infertility, but there is no evidence to suggest that it increases the pregnancy rate. And fourth is the pentoxifylline. It's a potent vasodilator. It prevents the platelet aggregation and reduces the blood viscosity. It decreases the tumor necrosis factor production. Along with tocopherol, it is very useful in the patients of radiation fibrosis. So pentoxifylline 800 milligram and vitamin E 1000 milligram per day improved the endometrial thickness. 6 to 9 months of the combined therapy may improve the endometrial thickness and pregnancy rate. So the therapy is to be given for 6 to 9 months and still its role has been found to be doubtful. Fifth is nitroglycerin. There are no specific publications and patch on the day of an embryo. Some people tried it, but it is not beneficial even if you apply it on the day before the embryo transfer. Sixth is an L-arginine. Therefore, they cause vasodilatation and increases the blood flow. The dose is 6 grams per day. It is more useful in radiation fibrosis. More evidence is required to evaluate its role. Seventh is an estrogen. 2015, Liu et al. Showed that it is duration of estrogen exposure that is important rather than the serum level. So if we are giving an estrogen, then it should be continuously given for a minimum 12 days and maximum up to 28 days. Then your pregnancy rates are very good. Many a times it happens that after 7th or 8th day of estrogen, you get a very good endometrium, but at least 12 days are required to get an excellent pregnancy rate. Sufficient level of estrogen should be given for the development of the progesterone receptors. Vaginal administration may be tried when the oral administration fails, but there is no clear-cut advantage or benefit of this route. But vaginal administration should not be done along with the progesterone. So when you start the progesterone, if you are using a vaginal progesterone, it should be shifted to the oral progesterone. Both cannot be given simultaneously. Estrogen-induced endometrial proliferation causes the spiral artery contraction and reduces the oxygen tension, which facilitates the embryo implantation. So whenever you give an estrogen for a longer duration, the thickness of the endometrium increases, and that presses on the spiral artery, and that's why the contraction, because of the contraction, it reduces the oxygen tension, and low oxygen is necessary. So if you see the graph, when the estrogen starts decreasing and progesterone start rising, this is an exact place where the implantation occurs. So estrogen has to come down, and this estrogen does not come down in endometriosis because the estrogen is already there, and that is why the implantation rates are very poor. Estrogen, if you are giving intramuscular, then twice a week injections can be given. Otherwise, 6 to 8 milligram is enough. Some of the papers are up to the 16 milligram can be given to the patient, but the majority of the patients, they require only 6 to 8 milligram only. Or those who cannot afford, then you can give an estrogen gel also can be applied to the patient. Endogenous estrogen is not required if you're for an FET transfer, and you can have the good endometrium with the exogenous estrogen. It can be continued. Estrogen, once the pregnancy occurs, then it has to be continued for 9 weeks in the frozen embryo transfers. HCG, there are the receptors present in a proliferative phase also. Day 8 or 9, 150 international unit of HCG is given for 7 days along with the estrogen 8 milligram daily, followed by the progesterone. This increases the endometrial receptivity. With normal endometrium, HCG has an opposite effect and should not be given. This is not rated by Human Fertility and Embryology Association. GnRH analogs. Luteal support with 0.1 milligram OD triptorelin on the day of an OPU. Second is on the day of the transfer, and third on 3 days afterwards. These 3 injections are given that can improve the endometrial receptivity. But this is the only study, no other study has validated this finding. Ovulation induction, tamoxifen can be used for endometrial proliferation. In FET cycle, 20 milligram per day can be given. It can be given when CC has given the thin endometrium. Tamoxifen can be combined with gonadotropin as a good alternative. We normally give letrozole and then combine gonadotropin, particularly recombinant FSH. We always give folicerts to these patients along with the letrozole, and then the quality of the follicle is very good, and then the endometrium can be very good to this patient. Letrozole plus GnRH analog given for 2 months improves the outcome for the patients of recurrent implantation failure. This effect is due to the undiagnosed endometriosis. In endometriosis, which is undiagnosed, or in an adenomyotic patients, when the adenomyotic uterus, if you give a letrozole, that will decrease the estrogen level, ectopic in the ectopic endometrium, the estrogen level will be reduced, and that will be very good, helping in implantation. Only GnRH analog does not give the very good results, but the combination of letrozole and GnRH analog, if given for 2 months, definitely improves the implantation. Low molecular weight heparin. Low molecular weight heparin did not provide any beneficial effect on the pregnancy outcome in recurrent implantation failure. But so many people give at present the low molecular weight heparin without its efficacy being confirmed. Add-on immunotherapy, IVIG does not increase the receptivity and it is not recommended by UK Department of Health. Corticosteroids are not recommended because of the safety reasons, Practice Committee of ASRM 2018. And intralipid does not improve the pregnancy rates, ASRM Practice Committee report 2018. So these are the drugs. Empirical therapy is very popular, or add-on therapy is very popular in patients with recurrent implantation failure or the reduced endometrial receptivity, but these are of doubtful role. Now, in the surgical procedures, what we have got endometrial scratching. It causes inflammatory reactions and favors the implantation. Cochrane review in 2015 suggests a benefit with the endometrial scratching, though the further studies are required for this. And endometrial scratching in the luteal phase before endometrial stimulation significantly enhances the clinical pregnancy rate in recurrent implantation failure, particularly more than 3 times. That is a multicentric trial. This is given in 2019. UK, Australia, and the New Zealand survey, 77% of the clinicians recommend endometrial scratching before IVF. 3.6% recommend before IUI. It is most commonly referred as an fertility add-on. But the recent large-scale multicentric RCT has found that the trial endometrial scratching in any subgroup does not increase the pregnancy rate. This was an international trial with a robust randomization procedure, pragmatic methodology, and minimal attrition and adequate sample size. So I think still the further research is required whether the endometrial scratching is going to help us or not. Second is GCSF. It stimulates the endometrial stromal cells. The study by Glacier et al. Showed the endometrial growth from 6.4 to about 9.3 plus minus 2.1 millimeter. It's not of use in a normal patient. ZL et al. Have documented in 2017 that it decreases the cycle cancellation rate. The dose is 300 microgram per ml of recombinant GCSF when endometrium is less than 7 millimeter. It is given 6 to 12 hours prior to trigger and repeated if no improvement is seen at the time of the pickup. But these findings are not confirmed by RCTs, and enhancing endometrial receptivity supports are lacking. So much more research is required for GCSF, whether it improves the endometrial receptivity or not. Third is the PRP. 30 to 60 ml of the fresh blood is centrifuged. It is used on day 9 and day 10 along with the estrogen. The dose is only 0.5 ml. Day 11 or 12, and you can repeat it on day 13 and 14, is recommended by Saizad et al. In 2017. This study claims that endometrial thickness increases after first dose and reaches 7 millimeter after the second dose. So it has the platelets release several growing factors like VEGF, TGF, EGF, and cytokines. It is safe and there is no risk of immune reactions or transmission of pathogens, but the larger studies are required to prove its efficacy. Last is an endometrial stem cells. The recent identification of the adult stem cells in both human and the mouse endometrium suggests that epithelial progenitor cells and the mesenchymal stem cell or the stromal cells have key roles in the cyclical regeneration of the endometrial epithelium and the stroma. Now, what is the basics? Angiogenesis results either from the local endometrial cells or from the neighboring vessels or by endothelial progenitor cells circulating in the peripheral blood after release from the bone marrow. So either from the endometrium or from the surrounding vessels or from the peripheral blood from where the cells come from the bone marrow. Now, sources of the stem cell, it can be a bone marrow, endometrium, amniotic fluid, cord blood, and adipose tissue. Then why we should take a bone marrow rather than all other alternatives? Taylor declared the donor-derived endometrial cells in the endometrial biopsy samples of the bone marrow recipients and concluded that the bone marrow is the most likely candidate as a potential source of endometrial epithelial and the stromal cells. This was a very good study because what they found in an endometrial biopsy, the donor cells which were given because of the bone marrow to the bone marrow recipients. So from the bone marrow, they must have migrated to the endothelium. Endometrial cells derived from the donor stem cells in the bone marrow transplant recipients. Endometrial cells can originate from the donor-derived bone marrow cells, and non-uterine stem cells contribute to the regeneration of the endometrial tissue. Significant engraftment of the endometrium by bone marrow cell is likely to occur after endometrial injury or the inflammatory insult. So whenever there is an endometrial injury or insult, the bone marrow stem cells, they come and they regenerate the endometrium. This was our paper, what we published in 2011, that endometrial regeneration using the autologous adult stem cells followed by the conception by in vitro fertilization in a patient of severe Asherman syndrome. This was the first paper, or rather the first of its kind, which was presented in the literature. The bone marrow aspiration was done from the iliac crest under local anesthesia and maintaining the strict asepsis using the bone marrow biopsy needle and 10 ml syringe pre-washed with heparin. Total 45 ml of the bone marrow was aspirated. The collection was done in citrate phosphate dextrose anticoagulant medium using 1 ml of the medium for the 7 ml of the bone marrow. The bone marrow was centrifuged using the histopec density gradient at 1000 rpm for 10 minutes and 102 million mononuclear cells were separated. These cells were then treated by the column separation technique, and customized cocktail of CD9, CD90, and CD133 antibodies were used for immunogenic magnetic isolation of the endometrial angiogenic stem cells. Markers used for the endometrial angiogenic stem cells were CD9, CD44, and CD90. Gene expression study of CD9, CD44, and CD90 using RT-PCR technique was done for differential cells. About 39 million marker-positive endometrial angiogenic cells were supplied in 0.7 ml of phosphate buffer saline with 2% autologous, that is patient's own heat inactivated serum, for transplantation on the next day for transplant. So on day 1, we take the bone marrow, and on day 2, we transfer this. Autologous stem cell transplantation in a refractory Asherman syndrome. This is a second paper in the literature in 2014, where implanting the autologous hemopoietic adult stem cells into a subendometrial zone in a new approach. So this is introduced into a subendometrial zone from an abdominal approach, or you may be transvaginal, but it is placed at a subendometrial zone. It is believed that the implanted stem cells may transdifferentiate into the resident endometrial stem cells and result into an abdominal and endometrial regeneration. Recently, Santa Marcia et al. 2016 infused bone marrow derived stem cells in spiral arterioles in 11 patients of Wassermann syndrome and documented increase in the endometrial thickness and pregnancy. So more or less now the research is going on exactly to put it inside or to put it at a subendometrial level or to put it in a spiral artery. The research is going on and we are waiting for the results. Now, the most important statement I would like to tell you today is that the frozen cycle have taught us that except estrogen and progesterone, all other substances from the ovary which are secreted are harmful for implantation. In a frozen embryo transfer, the ovary is absolutely quiet, and what we are giving from outside is the estrogen and progesterone only. And this estrogen and progesterone develops an endometrium, and then the implantation occurs. So all the cytokines, all the genetic factors, what we have discussed now, they are the results of the estrogen and progesterone. They are never the cause of decrease in endometrial receptivity. Either there is some fault at an estrogen level or some fault at a progesterone level that we have to find out. The further research is required, where how much estrogen is necessary, how much progesterone is necessary, because there are a lot of progesterones are given by majority of the consultants in a combo preparations. Some people give everything to the patient, but in spite of that, the pregnancy rates are not good. So that is why the research is required on how much estrogen and how much progesterone should be given to the patient. Our experience, we give in FET cycles, we give estrogen 2 milligram 3 times a day for at least for 12 days. And then we see how is an endometrium. The very important statement I would like to give you, when the vascularity develops in zone 3 in the evening, we start progesterone gel in the evening, and BD is to be given every day. Now, this is very important that the vascularity, if it does not develop in a zone 3, we never transfer or we never start the progesterone to the patient. Now, all the centers, what I've analyzed a lot of papers in the literature, and what they have found out as an implantation failure or recurrent pregnancy loss has not given anything as far as the vascularity is concerned. So what I consider that it is a personal failure rather than the recurrent implantation failure, or rather than reduced endometrial receptivity. If you develop a zone 3 or you cancel the cycle, you may not transfer the embryo, you may not start the progesterone to the patient, but till you get, I remember some of my patients where we have taken 2 months, 3 months, 4 months, in some of the patients 6 months, but unless we get the vascularity, we never start the progesterone, and we never start the progesterone, and we transfer only after giving a progesterone for 5 days. On day 5 we transfer, and our pregnancy uh, results are excellent. And so to get an excellent results, I think to in our hand, because we have got an ultrasound in our hand, and that is why we can see the vascularity in zone 3 and 4, and then we can start the progesterone, that is on day 0. Day 1, 2 and 3, 4, along with the gel, you should give an aqueous progesterone to this patient. Now, why you should add an aqueous progesterone? There is a beautiful paper in 2018 that only gel is given, then quite a good number of patients, they abort because the progesterone is not sufficient. And in these cases, the progesterone was added to all these patients. And when the progesterone was added, almost 33% of the patients who had aborted had continued the pregnancy and reached to full term. That is why gel along with an aqueous progesterone is a very important remedy as far as the endometrial receptivity is concerned. Formerly, the papers used to say about 50 milligram of an intramuscular injection. But as the intramuscular injection is very painful, and if you see the ROC curve, then the 25 milligram and the 50 milligram has got the equal efficacy. That's why you can give 25 milligram of the progesterone, aqueous progesterone can be given to the patient. So we do day 5 transfer, we get an excellent results, and I'm I would like to tell you honestly that we have never undergone any test as far as the ERA is concerned. And we always go for a vascularity. And I think much publications are necessary now rather than going for investigative protocol. If you see the vascularity, because this is a functional maturity, what you do, thickness of an endometrium is an anatomical maturity. But if you see the vascularity, it is a functional maturity of the endometrium, and that will give you an excellent results. So believe in ultrasound. That will be very useful as far as the endometrial receptivity is concerned. Thank you very much.
Thank you, sir, for giving an insightful lecture on the very challenging topic and with latest and updated evidences. All the viewers have complimented for the very best lecture. There are some questions, some of them I will be asking you. One of them is asking which method you prefer best. Almost everything is discussed, biochemical markers or US markers, and how do you means your what is your routine in everyday clinic?
In our clinic, majority of the patients, we go for the freeze embryo transfer. In a freeze embryo transfer, we always, whether the patient is menstruating or not menstruating, but we start with an estrogen and we keep the ovary at a quiet level and we give estrogen, and then we simply rely on only ultrasound. Unless we see the vascularity in zone 3 and zone 4, we never add a progesterone. Now, the estrogen maximum days that can be given are from day 12 up to 28 days. There are papers in the literature that for more than 28 days, if you give the estrogen, then the pregnancy rates are poor. So in some of the patients, in spite of giving it for more than 25 to 28 days, if we don't get the vascularity, we just cancel the cycle. And we try in the next cycle. Many a times we have observed that in second or third cycle, if there is no cause, then you definitely get a vascularity and then you get a good pregnancy rate. But if you don't get a vascularity, at least a pathological condition has to be ruled out in hysteroscopy, either an endometritis or is there any other abnormality inside. But if everything is normal, then we always rely simply on an ultrasound only.
Thank you, sir. Can ERA test, already discussed, can ERA test as a routine to increase success rate be used? No.
Not at all. I have said that there are a lot of papers which are against it also. And second thing is it increases the cost like anything. It will be doubled because you have to freeze the embryo, you have to transfer in the next cycle. You cannot do any fresh transfer in this patient. And that's why it's not good. And ERA is not that popular. It is only popular in some of the areas where it has been invented. Otherwise, it is not popular all over the world.
Sir, for assessment of receptivity, subendometrial vascularity, is it sufficient without using main uterine artery indices?
That's not enough. Uterine artery indices is equally common. Suppose you are doing a fresh transfer, then the uterine artery PI should be less than 3.2. If you do an embryo transfer when the uterine artery PI is more than 3.2, the embryos are wasted. The implantation will not occur. And that's why the uterine artery PI is equally important, particularly when you're stimulating the patient.
Sure, sir. One question is, what did you usually use to increase endometrial receptivity for your patients?
Suppose if you consider me the frozen transfer, then frozen transfer, we use only estrogen and progesterone. In a regular cycles only, that we give the progesterone support to the patient and we use aspirin. These are the only two things what we use as far as improving the receptivity is concerned. We don't use any other drug which are not found to be useful.
Right, sir. Sir, for ovarian stimulation, which recombinant FSH and HMG do you use in your clinic?
See, normally we always use the Folisurge, and particularly the pen. Folisurge pen is very convenient to the patient. Patient can take it very well, and the dose required of recombinant FSH is always less than the urinary FSH, because the recombinant FSH is prepared from a Chinese larva which is cloned in such a way that it mimics the peri-ovulatory FSH, while the urinary FSH is prepared from the menopausal urine, and that menopausal urine is having the least bioactivity, and that is why almost the dose is doubled, and that the efficacy is also less. That is why we always use routinely to all our patients the Folisar, that is recombinant FSH is used, and all our cycles are the antagonist cycle. We never go for the agonist protocol. We always use the citrolix as an antagonist. For all the patients, we use an antagonist cycle.
Right, sir. So most of the cycles are frozen cycle or
Most of the cycles, because see,
FET?
maximum number of patients we normally get in our IVF are the PCOS patients. We get a lot, and for them we always freeze the embryos and always transfer in the next cycle.
Right, sir. Sir, one question is it easy to get stem cell from adipose tissues?
I don't have personal experience, but some people are trying from, so there are few papers that they do get it, but the bone marrow, we get plenty of stem cells, and the results of bone marrow are very good. We have almost completed about 25 patients. That was our first patient. We have got almost about 25 patients. The only thing what we have not got the result are 3 patients where the damage was done because of tuberculosis. Whenever the damage is done with because of the tuberculosis, then the chances of regeneration of endometriums are very poor. I don't know whether the mesenchymal cells can help us or not. We are working on it, because you have to wait for almost about the 14 days for the mesenchymal cells to develop, and after pick up from the bone marrow, after 14 days you have to transfer it inside, but this is still under the research.
Sir, how can we increase endometrial receptivity and endometrial preparation for FET in patients with endometriosis and multiple chocolate cyst?
See, in an endometriosis, either you have to give for 2 to 3 months, you have to go letrozole plus GnRH analog. This is the standard procedure that we never transfer the patients. Even if we have done a pickup, we freeze the embryo, we never transfer in the same cycle. We always give GnRH analog as well as we give the letrozole to this patient. We wait for at least 2 months, 2 to 3 months are given, and then we do an embryo transfer. The results are very good. But as such, if you transfer in the same cycle, the results are not that good.
And sir, for chocolate cyst, do you operate or?
At present, the latest scenario is that you don't have to touch the chocolate cyst.
Right, sir.
You don't have to touch the chocolate cyst and do a pickup.
Right, sir. Sir, further one question is, thank you, sir. And they are asking, can we measure HOXA 10 and 11 from serum level, or it's only accurate if it is endometrial?
People say that if it is taken from an endometrium, then it is accurate.
Correct.
From a serum level, the results are not that confirmatory.
Right, sir. Other question is, please, what is the time of subendometrial injection of plasma cell and the maneuver, please?
I don't know. That is the paper by Neeta Singh that has been given in 2014. But they have introduced. Now, there is no question of timing, because here the endometrium is poor. These patients are either amenorrheic or they have the Asherman syndrome. So that can be put at any time. It can be put at any time. There's no specific day on which it will be done.
Right, sir. Does days of progesterone giving depend on embryo age?
Dose of progesterone? No, the dose of progesterone
Days,
only the
sir,
day varies.
sorry, sir, it's days of progesterone.
So if it is how you have freezed your embryos, if you have freezed the embryos for day 3, then you have to give it for 3 days. If you have freezed the blastocyst, then you have to give it for 5 days. So the progesterone days are according to the embryos which have been freezed.
Right, sir. The next question is, what is the most reliable endometrial marker in the serum or blood predicting endometrial receptivity and available in the markets, and in which day can be done?
No, we are not doing any marker, so I don't have a
Right,
personal experience.
right. In some time, so difficult to obtain zone 3 vascularity, can we proceed in zone 2 because it's more common than zone 3 and 4?
No, zone 3, unless it is zone 3, please don't transfer the embryo.
So you have to cancel the cycle.
You have to cancel the cycle. But you have to do your settings properly. That is very important. Many times you don't get a vascularity because your settings are not proper. And 3D power Doppler, you should be well versed with it. Then and then you can pick up the vascularity in zone 3 and zone 4.
One question is, what is the role of uterine fibroids, adenomyosis in endometrial receptivity?
I told you that if the fibroid is more than 4 centimeters, then there are papers that it can affect the endometrial receptivity, and any fibroid more than 4 centimeters should be operated. Any fibroid which is submucous is always to be operated. It always changes the endometrial receptivity. So for a fibroid, if it is less than 4 centimeters, not touching an endometrium, not changing the shape of an endometrial cavity, then it's not required to be operated.
Sir, already discussed, but they are asking role of PRP, your personal experience in enhancing endometrium.
No, I don't have my personal experience. Very few cases we have done, and we have not found to be that useful. But still, we are waiting for the large series, and then we can opine.
Right, sir. And for endometrial receptivity, can we rely, if we don't have all the gazettes, only on endometrial thickness?
No, not at all. See, I tell you to one thing. Suppose you don't have a good gazette that is a sophisticated machine. If you have only 2D ultrasound machine, then if you see exactly, then you can get a triple line endometrium. Now, if you observe this triple line endometrium, in a triple line, there will be two, grade B and grade A. In a grade B, there will be sonolucent area among the 3 lines. Now, why it is sonolucent? Because the vascularity is not developed, because there is no glycogen deposition in the columnar epithelium in this. So wait for a day or two till the endometrium matures. And when it matures, the vessels enter inside, and then you get an echogenicity among the 3 lines, which was sonolucent before 1 or 2 days. After 2 to 3 days, it becomes you can get an echogenic endometrium. That is a very good endometrium where you can go for the transport.
Right, sir. And what about your personal experience on endometrial scratching?
See, we initially tried in some of the patients, but the results were not encouraging, and that's why we have left that procedure.
And they are also asking, what is the status of ART in India currently?
What is the status of ART in
ART
India?
in India in this COVD?
ART is now the most acceptable, perhaps, the treatment by majority of the Indian people. But still, I would like to tell you only one thing, that you should try IUI properly for 3 to 6 cycles. And if the patient does not conceive, then and then you should go for an IVF, particularly for idiopathic infertility, dysovulatory infertility, male subfertility, or the endometriosis mild degree. Otherwise, all indications for blocked tubes or low count or womb donations or 3rd or 4th degree endometriosis, you have to undergo for IVF. But don't jump for IVF immediately if you have an unexplained infertility or dysovulatory infertility. These patients respond very well with recombinant FSH, with very well with good ultrasound monitoring and IUI. The pregnancy rates are very good. I can put it in that way that 85% pregnancy rate is there with 6 cycles in a patient of unexplained infertility or dysovulatory infertility. If you use recombinant FSH, that is Folisurge, and if you have a good ultrasound with 2D and color Doppler, then your pregnancy rates will be very good. Then and then only you should go for an ART.
Right, sir. So you recommend or your experiencing mainly with gonadotropin cycles in IUI.
Only rather, I would say we never do any cycle with the clomiphene or letrozole. We always do all gonadotropin cycle, because many a times what happens that the patient has undergone 1 or 2 cycles, 3 cycles somewhere, and ART consultant feel that it is an IUI failure. So it's not an IUI failure. IUIs are not done properly. If you feel, then you should do an IUI with the gonadotropin stimulation, good ultrasound preparations, and then post IUI remedy should be given properly. Then and then only you should consider it as an IUI failure. Otherwise, it is a personal failure. So I always believe that majority of the failures are at a personal level, not at a pathological level.
Correct, sir. And what dosage do you use for gonadotropins?
In an IUI, we use this Folisurge pen, that is 75 international unit. We start from day 5 we give it for 5 days in a normal responding ovary. But if it is a PCO, then we start with 37.5 and we may continue up to 14 days. And then we develop a follicle, because in an IUI we require 1 or 2 follicles only, not more than that. And that's why we start with a lower dose with this. Otherwise, in an ART, we start with 150 or 225. We have got our own paper, how we should stimulate the patient and what should be the dose as far as the calculation is concerned, based on an ultrasound only.
Thank you, sir. And one question is, as we discussed for endometriosis, letrozole, they are asking letrozole plus GnRH agonist continuous, but what would be the dose of letrozole and the GnRH agonist?
The GnRH agonist, you can give it as a depot also every month, and letrozole is 2.5 milligram daily should be given to the patient.
Okay, sir. And one question is, how to diagnose asymptomatic endometritis in patients?
Asymptomatic endometritis only by hysteroscopy. If you see that the polypoidal growth in an endometrium or hyperemia, if you see, then and then you should suspect an endometritis. Otherwise, symptomatic you can diagnose, but asymptomatic, the hysteroscopy will be very useful to diagnose.
And sir, when to start GnRH agonist with letrozole? Means before 2 to 3 months, they are asking.
No, if you have done an ovum pickup, then you should start it immediately afterwards, and then after 2 to 3 months you should do an embryo transfer. But if you have not done an ovum pickup to the patient, then you go it for 2 months, then you can stimulate, and then you can do a fresh transfer also.
Right, sir. What is the most appropriate time for taking ultrasound to identify its thickness?
Most appropriate
time for taking, using ultrasound to identify the endometrial thickness?
See, normally it will vary from which procedure you are doing. If you are doing an FET cycle, I will do straight on day 12. If I'm giving an IUI cycle, then I give a gonadotropin for 5 days, and then I see. After 5 days, I do an ultrasound. If the endometrium and follicle both are increasing, then I will continue the same dose. Otherwise, I will increase 1 ampule more. So it will be depending on which gonadotropins you are giving, or you are going for FET cycles.
Right, sir. And one more question: estrogen used in ovulation induction to increase the receptivity?
Not at all. It should never be used.
Right, sir. With this, there are many questions, but the time is the constraint. They all have complimented you. There is one question: what is your opinion about given FSH at day of trigger with HCG in IUI cycle?
There is only one paper that is that FSH and HCG can be combined together, can be given. But if your follicle has already developed on that day, there is no point in giving FSH. It is better to give HCG, and then you can do an IUI after 36 hours. Right. So at least there should be a gap of more than 12 hours between the FSH and the HCG.
Thank you, sir, for the very informative and interactive session. And I thank you on behalf of Intas and all the viewers. Thank you, sir.
Thank you very much.
Thank you so much, Professor Nagori, for this scientific and nice presentation lecture. And also, I want to thank Intas company to allow us to do this webinar with you, and thank the audience for attending this webinar. Thank you so much.
Thank you very much. Thank you very much.
Thanks a lot, Madam Manal, for organizing this activity, this session on behalf of Ayurveda Society of Iraq. And thanks a lot for Professor Nagori for taking out his valuable and his time out of his busy schedule and helping us out during this COVID time with this lecture. Once again, thanks a lot, sir. Thanks a lot, Pam. Thanks a lot, Sonal, madam.
Thank you, sir.